Hello dreamers, in this video we're going to talk about schizophrenia and other psychotic disorder. So we're going to discuss psychotic disorders, which is schizophrenia, a very important topic, and we'll also cover other psychotic disorders like acute psychosis, delusional disorders, schizoaffective disorder. We'll also learn about the management, especially the psychopharmacology part, which is antipsychotics. So let us begin. Schizophrenia is a prototype of psychotic disorder. It is one of the common severe mental illnesses. Let us talk about the history of schizophrenia. Benedict Morel, he coined the term dementia precoce. So he saw certain patients which now when we read the description, it seems like they were having schizophrenia. So he identified schizophrenia at that time, symptoms which were similar to schizophrenia, and he coined this term. Then came Emil Kraepelin. Kraepelin coined the term, so he translated that term and he coined the term dementia precox. Okay, now, and also he did was he divided the psychiatric illnesses into two. One he classified as people having dementia precoce. Precox means early onset. Okay, so he identified those patients and which were having a long-term deteriorating course, and also there was cognitive decline in these patients was present. For example, there were disturbance of memory, language, attention, those were there. And second, he classified the psychiatric illness into manic depressive illness or manic depressive psychosis. These patients would have episodic illnesses, that is, there was a period of normal functioning. They would have episodes of disturbance and then there was normal functioning. And he found that there was no cognitive decline seen in these patients. So these were important contributions of Emil Kraepelin. Then came Eugene Bleuler. Bleuler coined the term which we now know, schizophrenia. So the term schizophrenia was coined by Eugene Bleuler. Schizophrenia basically means, schizo means split, while phrenia means mind. So he identified those people having split in the mind, that is there was split between their thoughts versus their feelings. So what the person is thinking was not in sync with his feelings or emotions, so that he coined the term as schizophrenia. Bleuler also gave certain symptoms. So the term which he coined schizophrenia, he said that these patients are having certain symptoms which are known as Bleuler's 4 A's. So what are these 4 A's? This is association disturbance, affect disturbances, autism, and ambivalence. Okay. Now, association disturbance means there is problems in the association of the thoughts. The thoughts are not connected properly. So like loosening of association and formal thought disorders which we had discussed in the basics. Then there are also affect disturbances like flat affect. Flat affect is that the emotions don't change. So whether you're talking about something good, you're talking about something bad, but the patient's emotions or affect does not change. These are some of the affect disturbances. Then autism. He said that these patients have fantasy thinking. Their thinking is very irrational and often they have socially withdrawn behavior. So that he termed as they were having autism. And lastly, ambivalence. What is ambivalence? Ambivalence is inability to take decisions. So these patients, at the level of their thinking, they are stuck, whether they should do certain thing or not. For example, suppose there is a pen on the table. So person with ambivalence in his mind is thinking whether I should pick this pen or not. So he's stuck in his mind, he's not able to decide. So many a times, the people around him will complain that he's, let us say, he's staring at this pen for a long time. So he's stuck in his mind. So this is ambivalence. These are Bleuler's 4 A's, important. Now, then came another gentleman with the name Kurt Schneider. Now, Kurt Schneider, tried to explain symptoms of schizophrenia, and he gave what is known as Schneider's first rank symptoms or the SFRS. Now, let us understand, important SFRS. Some of these SFRS we have already discussed in the basics. Okay, so the first is, let us combine these. So first three let us discuss. First is audible thought or thought echo. So as we had discussed, in the basics, what is this? Here the patient says that he is able to hear his own thoughts. Okay, so this is audible thoughts or thought echo. Second is voices discussing the patient or discussing about the patient. So patient says, that he hear voices. So there are two or more voices which are discussing about him. For example, he hear the voices which are saying that look at him, he's such a bad person, or look at him, what he's doing. So again, these are types of third person auditory hallucination. And the third is voices commenting on the patient's actions or giving a running commentary. Okay, so patient hear voices, for example, patient, when he gets up in the morning, he says that I hear a voice that, the voice is saying, now he's got up from the bed, now he's going to the washroom, now he's come back, now he's going to the kitchen, now he's started eating, and now he's getting ready for his office. So there is a continuous running commentary in the form of third person. So these are again our type of third person auditory hallucination. So these three are the types of auditory hallucinations which are described as SFRS. Now if I ask you, are all the auditory hallucinations SFRS? No, only these three particular auditory hallucinations are included in the SFRS. Now let's discuss the next three symptoms together, which is thought insertion, thought withdrawal, and thought broadcast. Again, we have discussed all these three, we have discussed under possession of thought. They are included under thought alienation phenomena. Thought alienation phenomena. Okay. That means that the thought are under some outside influence. Thought insertion means patient says that someone is putting thoughts in my mind. So patient says, sir, I am getting a thought in my mind that I should go and get a piece of cake. Now, but patient says, sir, this thought is not mine, someone is inserting this thought in my mind. This is thought insertion. Then thought withdrawal, patient says that my thoughts are getting withdrawn from my mind. So patient may say, or he may experience that, there was a thought in my mind few minutes back, but right now I'm not able to know, what that thought was. Somebody has taken away my thought. And thought broadcast is when the patient says that my thoughts are getting broadcasted outside. People outside are able to know my thought. I enter a room and everybody inside the room are able to know my thought. This is thought broadcast. So again, these are SFRS. Now, let's talk about the next three SFRS, which is thought impulses, thought feelings, or sometimes also known as made affect and made acts. Okay, so these are made impulses, made feelings, and made acts. You can also remember with this mnemonic. So there are IFA awards in Bollywood. You can remember like this: IFA, impulses, feelings, and acts. So what is this? So basically, made means someone is making me have these impulses or feelings, or someone is making me do certain things. So patient experiences that his impulses, his feelings, or his acts are under some outside influence, or someone is influencing it from outside. For example, a patient says, sir, I am getting recurrent impulses or recurrent urge to stand up. I don't want to stand, but I am getting these recurrent impulses. Someone is putting these impulses in me. So this is made impulses. Okay. Then made feelings. Okay. So let us say there is a patient who is crying. And when I go and ask him what happened, the patient says, sir, this crying, this emotion is not mine. Someone from outside is making me feel like this or making me cry. So this is made feelings, that these feelings are not mine. Someone is making me experience these feelings. Then made acts. So let us say there is a patient who slapped another patient. So we go and ask him why did he slapped that person. So he says, sir, this act which is done by me is not done by me. Someone is making me do this. So someone from outside has made me slap that person. So this is made act. Okay. So these are the next three symptoms of SFRS. Now the 10th symptom is somatic passivity. So next is somatic passivity. What is somatic passivity? Patient is a passive recipient of bodily sensations. So patient is a passive recipient of some bodily sensation. Patient is experiencing some bodily sensations. Okay, now these sensations can be true sensations, or these can also be, like tactile hallucination. But there is some bodily sensation which, according to the patient, is imposed by some external agency. Some external agency from outside is making him experience these bodily sensations. This is somatic passivity. Now I always say, try to remember it from the name. So you can remember from the name itself that patient is a passive recipient of somatic sensation. So patient is a passive recipient of somatic or bodily sensations which are imposed by some external agency. Let us take an example. So we had a patient, Mr. Bholu. Okay, so he complained of pain in his abdomen. He came and he said that I am having pain in my abdomen. Okay, there is a bodily sensation, and he said that these sensations are because of some radio waves which are sent by the aliens from another planet. Okay, so now if you see, there are two components. One is he is having some sensations, which he is attributing it to some external agency. So this is somatic passivity. Okay, this is somatic passivity. Another example, a patient says, I am having headache, and he says this headache is because of black magic done by my neighbor. Okay, so again there is some bodily sensation which the patient is convinced that it is because of some external agency. So this phenomena is known as somatic passivity. Okay, now the next or the last SFRS is delusional perception. Okay, delusional perception. What is delusional perception? Here again, patient experiences a normal perception. Okay, so experiences a normal perception which can be experienced by any of us. Okay, and he gives a delusional meaning to this normal perception. So this is delusional perception. Okay, let me give some examples. So suppose patient goes in a party and he sees a spoon. He sees a spoon with a crown. He sees a spoon with a crown. Now this is a normal perception. This is a normal perception. Anybody, anybody can see this crown. Okay, anybody can see this crown. And immediately after seeing this crown, the patient started claiming that he is the king of the world. He stood on the table and he said to all the people around that I am your king has come. So he's totally convinced that he's the king of the world. Okay, of course other people are laughing, they are not able to see what is happening, but the patient is totally convinced that he is the king of the world. So this is what is known as delusional perception. Please understand both these phenomena, that is experiencing a normal perception and developing this delusional meaning, they occur simultaneously. They occur simultaneously at the same time. It's not that he experienced a perception, normal perception, and 10 days later he developed a delusion. No, it occurs at the same moment. So this is delusional perception. Okay, now again, try to remember it from the name itself. The concept will become very easy. So delusional perception, if you see the name, a normal perception is given a delusional meaning. Normal perception is given a delusional meaning. This is delusional perception. Another example, let's bring in another patient. So we had a patient, Mr. Golu. So he saw his wife in red clothes. Okay, so this is a normal perception. Anybody could see, his wife wearing red clothes, and immediately he started doubting that the wife wants to kill him. He's totally convinced that his wife wants to kill him. What is this? This is a type of delusion of persecution. Delusion of persecution. So look, there is a normal perception and again immediately there is a delusional meaning developed to it. Just like in the previous case, when the patient says I am the king of the world, which type of delusion it is? It is delusion of grandiosity. It is delusion of grandiosity. So if you see, any type of delusion may occur. Okay, so these are the important SFRS. Now also let us try to understand this. Delusional perception, we say, is a primary delusion. Let's try to understand this concept. It's a primary delusion. That means, it is a direct result of the underlying disorder, and this is not because of any other morbid phenomena or any other symptom. Okay, so such type of delusions are known as primary delusions. They occur, without, without any other cause. Okay, while there are secondary delusions, which are derived from some morbid psychological phenomena or from some other symptom. Let us say a patient is having mania. Let us say, so mania is a mood disorder. Patient is, elated. Patient has lots of energy. Patient has, extremely high self-esteem, or they are in a, there are grandiose feelings are there. And in this feeling, patient started saying or started believing that, I am the most powerful person, or I know very, famous people. So he has developed delusion of grandiosity. So this delusion of grandiosity is because of the mood state the patient is in. Such type of delusions are known as secondary delusions. Okay, so this is how we differentiate. So delusional perception is a primary delusion. So let us, just, write all these SFRS together. So if you see, the first three are types of auditory hallucination, but not all auditory hallucination are SFRS. Then these are thought alienation phenomena. Then three MAIDS phenomena is there: somatic passivity and delusional perception. Now, let's talk about the epidemiology of schizophrenia. The lifetime prevalence, initially, earlier in earlier studies, it was seen that the lifetime prevalence of schizophrenia is 1%. But, recent studies and recent book, that is, Kaplan and Sadok Synopsis of Psychiatry, says that the worldwide prevalence of schizophrenia is around 0.7%. Okay, then point prevalence is 0.5 to around 1%, and incident rate is 0.15 to 0.25 per 1,000%. Okay, so these are important. Now this is again important, and there is a, recent data shows it is 0.7%, that is the lifetime prevalence. Now in epidemiology, we say schizophrenia has a high hereditability. Okay, and prevalence is higher in the relatives. Okay, so let us talk about prevalence of schizophrenia in certain specific population. Okay, now in non-twin sibling, so if one sibling has schizophrenia, so the prevalence of schizophrenia in the non-twin sibling is around 8%. Okay, is 8%. Then child with one parent having schizophrenia, the prevalence of that schizophrenia in the child is around 12%. Is around 12%. Again, this has been asked, in previous exams. Child with both the parents, with schizophrenia, again, since both the parents, again, the chances will be higher. It is 40%. So the prevalence is 40%. In dizygotic twins, we say it is again 12%. And in monozygotic twins, again, they share the same genetics, so the prevalence again is high, that is 47%. And especially, child with one parent with schizophrenia, monozygotic twin, these have been asked previously as well. Okay, so these are some of the prevalence in certain specific populations. Now coming to the gender, so which has, more schizophrenia, when, is it males or females? In fact, we say it is nearly the same. Okay, so it is same. The prevalence is nearly the same in males and females. But there are certain important, differences. A male having schizophrenia and a female having schizophrenia. So first is the peak age of onset. So peak age of onset, we say in males. So most of the males, in what age they generally develop schizophrenia, it is, somewhat early, around 10 to 25 years, while females tend to develop schizophrenia at a slightly later age. Okay, so peak age of onset is around 25 to 35 years. Okay, and in fact, we say in females they have a bimodal distribution. Okay, so one peak occurs at the age of around 25 to 35 years, and another peak occurs, somewhere around in the middle age at around 40 years. Okay, so in females we see that the schizophrenia has an onset at slightly later age than men. Now then we talk about the prognosis. So prognosis is outcome. So if we compare, male having schizophrenia and female having schizophrenia, who, has a better outcome? Now you can understand it like this: schizophrenia is a severe mental illness, and if someone develops this, a lot of, so in males it occurs at an early age, the age in which the person, develops, the person learns so many things, he has developed a severe mental illness. Okay, so again his course may be deteriorating. So we say males have a poor prognosis, while females have a better prognosis. They have a better prognosis. It is occurring at a later age. Okay, so this is some important points between male and female. Okay, now there is another important concept which is late onset schizophrenia. Now try to understand it like this. Now if we say does schizophrenia occur at an early age? Let us say this is early age and this is late age. So schizophrenia, we have learned, in both males and females, it is occurring at an early age. Okay, while there are certain, small subset of patients who develop schizophrenia at a later age. Okay, so these small subset of, fraction of patients we have termed as late onset schizophrenia. They develop schizophrenia for the first time at a later age. So the onset of schizophrenia, in late onset schizophrenia is after 45 years of age. So those patients we say that they have late onset schizophrenia. So what will be the prognosis? What will be the prognosis of such patients? Okay, since it is occurring at a later age, again we say they generally have a better or they have a good prognosis. They have a better prognosis. Okay. Now also, based on the body type, we've seen that, again we can divide the body type into three, that is asthenic build or thin build, then athletic build or muscular build, and picnic build, that is short and fat build. Now again it is seen that asthenic build and some somewhat athletic build patients, they are more at risk of developing schizophrenia. They are more at risk of developing schizophrenia, while picnic build patients, it is seen they are more at risk of developing bipolar disorder. Okay, bipolar disorder, right? Now let's talk about the etiology. Now when we talk about etiology of psychiatric disorders, there is no one particular etiology. Okay, there are multiple factors which play a role in the development of these disorders. So let us talk about the etiology of schizophrenia. Now first is the genetic factors. Now again in genetic factor it is seen that monozygotic concordance rate is higher than the dizygotic concordance rate. So schizophrenia in monozygotic twins, it is more common than the prevalence is higher than the dizygotic twins. So again it shows that there is involvement of genetics. Again also it is seen that there is a higher risk of schizophrenia in family members of patient with schizophrenia than the general population. Again it shows that yes, genetics has an important role, and even there is higher risk of schizophrenia in family members who also have bipolar disorder. Okay, so there is a higher risk. Now there are various linkage sites which have been identified which increases the risk of schizophrenia. So these are 1q, 5q, 6p and 6q, 8p and 10p, 13q and 15q and 22q. Okay, also there is a disorder which is chromosome 22q11.2 deletion syndrome, or also known as Dijor syndrome or vellocardo-facial syndrome. It is seen that around 30% of these patients develop schizophrenia. Okay, then there are certain individual genes which have been candidate genes which have been identified. Let us try to understand or name some of them. Again, there is no one particular gene which is seen in all the cases. In various population, various subset, different genes have been identified which may play a role in development of schizophrenia. So some of them are, first is DTNBP1, that is dystobravin binding protein 1 or disbinding, NRG1 or neuroglin 1, then DISC1 or disrupted in schizophrenia gene, then COMT gene, catechol O methyl transferase. Okay, then GRM3, that is glutamate receptor metabotropic, RGS4 regulator of G protein signaling, and DAOA or G72, that is D amino acid oxidase activator. So these are some of the genes which have been identified. Now second and very important is the neurotransmitters. So there are one of the important neurotransmitter is dopamine. So there was a dopamine hypothesis. There was a dopamine hypothesis earlier which was given, which used to say that there is increase in dopamine in the brain of the patients who develop schizophrenia. Okay, so it was an earlier hypothesis which was believed that there is an increase in the brains of schizophrenia. So dopamine is a very important neurotransmitter implicated in schizophrenia, right? Now we know, as our understanding of schizophrenia is improving, now we know that dopamine has various pathways. Now two important dopamine pathways have been postulated for development of symptoms in schizophrenia. First pathway is the mesolimbic pathway. So meso means midbrain, limbic means the limbic system. So it starts from the midbrain, that is the midbrain. So which part of the midbrain? From the ventral tegmental area to the limbic system, that is to the nucleus accumbens. Now it is seen that it is actually increase in dopamine in this pathway. So patients with schizophrenia, it is seen that there is an increase of dopamine in this pathway, which leads to what is known as positive symptoms, which is known as positive symptoms. So positive symptoms of schizophrenia, which we are going to discuss, which are delusions and hallucinations, occur because of increase in dopamine in this pathway. Okay. Then there is another pathway, which is the mesocortical pathway. Mesocortical pathway, again meso means the midbrain. Which part of the midbrain? That is the ventral tegmental area to the cortical region. Which part of the cortex? To the prefrontal cortex. So it goes from VTA to the prefrontal cortex, and it is seen in patients with schizophrenia there is actually a decrease in dopamine in this pathway, which leads to what is known as negative symptoms of schizophrenia. Okay, so we are going to discuss what are these negative symptoms. Okay, so again, as our knowledge is improving, now we know that it is in one pathway there is increase and in another there is also decrease. Okay, but please remember there is an increase in dopamine, which we will use, this concept we will use when we will talk about the treatment of schizophrenia. Okay, now we know not just dopamine but other neurotransmitters are also playing important role. Okay, so one is serotonin. Again, it is seen that there is increase in the serotonin levels, okay, in the brain of the patient with schizophrenia. So again, we'll use this concept when we'll talk about atypical antipsychotics. When we'll talk about the mechanism of action, we'll use this concept. So even serotonin is increased. Then even other neurotransmitters like GABA, glutamate, norepinephrine, acetylcholine, these are also seen to show certain changes in the patient with schizophrenia, and it is seen that these are decreased in the patient with schizophrenia. Okay, so a lot of neurotransmitters are now implicated, but again, most important is dopamine. Now let's talk about certain neuropathological factors. Okay, so there are certain changes which have also been seen in the patient with schizophrenia, like in the cerebral ventricles. It is seen that there is a reduction in the cortical volume, the gray matter, there is a decrease in the volume, which and also it is seen there is enlargement of the lateral and the third ventricles. Okay, so these are again important findings, some of the important neuropathological findings which are seen. Also other regions like the limbic system is also affected. It is seen there are structural abnormalities. There is a decrease in the size of hippocampus, amygdala and parahippocampal gyrus, and also functional abnormalities are also seen in hippocampus. Okay, so in limbic system there are structural and functional abnormalities seen. Then in the prefrontal cortex also there are structural and functional abnormalities seen. Thalamus, again there is seen neuronal loss, especially in the medial dorsal nucleus of the thalamus. Okay, basal ganglia and cerebellum also have been reported to show certain abnormalities like decrease in the size, but these findings are inconsistent. So a lot of areas have been seen having certain abnormalities in schizophrenia. Now then there are certain other factors, including certain environmental factors, which have been also shown to you know, have certain effect in the development of schizophrenia. So let us, divide them into two. Let's divide them into, early developmental factors and, factors which occur in childhood or in adolescent period. Let us talk about early developmental factors. So parental age, that is at the time of, at the time when the patient was conceived, let us say, so at that time if the age of the father is more than 60 years, okay, so there is a risk of development of schizophrenia in the child, okay, so who is conceived at, when the father's age is more than 60 years. Even seasonality of birth also has been shown to have certain effect, okay, so people who are born in winter or early spring, again they have been shown to have higher risk of development of schizophrenia. Now maternal factors, okay, so when the mother was pregnant with the patient, okay, so certain factors may play a role during that time. So if there are certain complications, so these complications can be during the pregnancy, like preeclampsia, there is bleeding, or during the birth there is premature premature birth is there, or the child has low birth weight, or there are certain abnormalities in the baby, or during the delivery there is asphyxia, or there is an emergency cesarean section. So these complications again have been seen to increase the risk of development of schizophrenia. Even infections during the pregnancy, if the mother develops infection, especially influenza infection, again important. If the mother has influenza infection during the pregnancy, again the risk of schizophrenia is high in the child. And again, if the mother is in a malnourished state during the pregnancy, again that can lead to development of schizophrenia. Okay, so these were some of the early developmental factors. Now factors which may play a role in childhood or in adolescent which lead to schizophrenia. So if there is history of childhood trauma, or there is there is a lot of social isolation is seen, again it may predispose to development of schizophrenia. In urban upbringing, again it is seen people who are brought up in urban setting, they are more or higher risk of schizophrenia. Now cannabis use, substance, one of the important substance associated with development of schizophrenia is cannabis. Okay, so people who are exposed to cannabis, again they may have a higher risk of development of schizophrenia, and there is some genetic basis to it as well. It is seen if people who are homozygous for the COMT gene, catechol O methyl transferase gene, that is valine allele, if these people are exposed to cannabis, again the risk of schizophrenia is higher than the homozygous COMT methionine allele. Okay, so there is some genetic basis as well. And another important factor is migration. So if someone migrates to another place, migrates to another country, there is a risk of development of schizophrenia. Especially this risk is more to the second generation. So generation which is born in that migrated place. So let us say a couple migrates to another country. So risk of schizophrenia is higher to their child, okay, to the second generation. So these are some important factors which may play a role in development of schizophrenia. Now let us talk about the symptoms of schizophrenia. Okay, the first set of symptoms are positive symptoms. Okay, positive symptoms. Let us talk about these positive symptoms. The first is delusion. As we had discussed in the basic, delusions are false, fixed, firm ideas or belief which is held with extraordinary conviction. Okay, so delusion, again we know there are so many types of delusions. Most common delusion in schizophrenia is delusion of persecution. Now there can be any type of delusion can be seen. Okay, the most common is delusion of persecution. There can be delusion of reference, even nihilism, all such kind of delusions can be seen. Okay, this is first positive symptom. Second symptom is hallucinations. Again, hallucinations, as we had discussed, these are false perception without any real object. Okay, again hallucinations are of various types: auditory, visual, olfactory, gustatory and tactile hallucination, and in schizophrenia or any of these can be seen. Most common hallucination in schizophrenia are the auditory hallucinations, are the auditory hallucinations, of course, but other hallucinations can also be seen. The positive symptoms are also known as psychotic symptoms. These are also known as psychotic symptoms, and when we see that these symptoms, they respond well to medication. So they respond well. So medication, when we give, they generally respond to these medications. So generally we say that positive symptoms have a good prognosis. They have a good prognosis, okay, or a better prognosis. Now, so these are one type of symptoms. Another type of symptoms are the negative symptoms. These are the negative symptoms. So as we have discussed, how these negative symptoms occur, they occur because of decrease in dopamine in the mesocortical pathway. Okay, so let us try to understand these negative symptoms. So first negative symptom is anhedonia. Anhedonia, what is anhedonia? There is a decrease in interest or loss of interest. So in activities which earlier the person used to enjoy, like going for movies or playing some sport, these patients now don't show interest in these activities. So this is anhedonia. Next is avolition. Next is avolition. What is avolition? Avolition is loss of will or drive. So family members say, now we give him any task, anything, he does not show any will to do that. Okay, as if there is loss of willpower or loss of motivation. This is avolition. The next is affective blunting. So if you remember in the basics, you've discussed flat affect or blunt affect. So that is inability to express emotion. So again you're talking something good, you're talking about some good event. Let us say the patient got promoted few months back, but the patient is just looking like this. There is no change in the emotions. Okay, or you talk about something sad in his life. Let us say a few months back there was a death in the family. Again the patient does not show any emotion. He just looks like this. So this is affective blunting. Then there is asociality. Asociality, there is a decrease in the drive to socialize. So family members may say that we take him outside to in social gathering, he does not socialize, or someone comes and meet him at home, he does not socialize with them. So there is asociality. Okay, then next is alogia. So again from the name itself you can remember what is logia. Logia means word. If you remember, we talked about neologism in the basic. Neologism was new word. So logia means word. So alogia means there is a decrease in the verbal communication. So family members say that the mother may say that I'm talking to him for 5-10 minutes, I'm speaking, but he may just reply in 1 or 2 words, or he may not reply anything. So there is a decrease in the verbal communication or verbal output. Next is attention deficits. So again there is in these patients attention is also seem to be decreased. Okay, so in there will be in social gatherings they would have inattention, and even while you're talking or interviewing, it will seem that they are not able to pay attention. So there is decrease in attention. And lastly there is apathy. There is loss of concern, lack of concern. So again family members may say that we come to him and we are crying in front of him, but he does not show any concern, as if there is no concern there. Okay, so this is lack of concern. So these are some of the negative symptoms which are seen in schizophrenia. Now if you see why are they called negative symptom, if you can see everything is everything is minus, everything is getting reduced, everything is getting reduced. So that is why these are known as negative symptoms. And again negative symptoms, they do not respond well. So they don't respond well to medication. So somebody having negative symptoms, they may not respond well with the medication. So we say negative symptoms have a bad prognosis. They have a bad or poor prognosis. Now let's talk about the next set of symptoms, that is the disorganized symptoms. Disorganized symptoms. So there may be disorganization in the speech or thought. So there is disorganization in the speech or thought. So all the all the formal thought disorders, which we have learned, formal thought disorders. So formal thought disorders basically is there is disorganization in thinking, like loosening of association or derailment, tangentiality, neologism. So all these are examples of formal thought disorder which may be seen. Then there may also be disorganization in the behavior. So there may be disorganized behavior, okay, or very inappropriate behavior, So there may be very, socially inappropriate behavior. For example, family members may complain that the patient went to the garbage, he put his hand in the garbage and picked out something and he started eating. So there may be very gross, disorganized behavior may be seen, okay, or there may be inappropriate affect, okay, that is, so inappropriateness in affect we say is with respect to the setting or the social situation. So it may be inappropriate to that setting. For example, the person goes to a funeral of his family member, so it's a situation where everybody is sad and the patient starts laughing. So this is inappropriate affect, okay. So these are some symptoms of disorganization. Even catatonia, which we are going to discuss, is also described under disorganization, but let us try to understand the next symptom as a separate symptom, that is catatonic symptoms. Catatonic symptoms, or they are basically motor symptoms. So they are basically set of motor symptoms which may be seen in patients with schizophrenia. The term catatonia, C for catatonia, you can remember, was coined by Carl Kalbaum, okay, Carl Kalbaum. So he defined the term catatonia and also some of these symptoms which he defined. Let us try to understand these symptoms. So I've clubbed these symptoms together, so it becomes easy for us to understand these symptoms. So let us understand the first symptom is stupor. So the patient here is in a stupor state. So patient is extremely hypoactive or immobility or akinesis. Okay, so patient may be just lying down, not moving much, not much responding to the external stimuli. He may be in a stupor state. Then some patients may be in excited state, that is excitement. They are extremely hyperactive and they are involved in goal directed activity. They are just moving around, involved in some activity which is not any productive activity. So in the hospital you may see a patient is just running around, not sitting at one place, okay, just doing certain things which is not productive, not goal directed. This is excitement, okay. So there may be maybe stupor and there may be excitement. It may be seen in one patient as well. So a patient for in one state is in a stupor state and in the other moment he may be in an excited state, okay. Then next is mutism. Just like we can mute the television set, so the screen is moving, the video is moving, but you cannot hear anything. Similarly, as if you have muted the patient, okay, so there is no or little verbal response. Patient is moving around doing things, but there is no verbal response. So this is mutism. Now next two symptoms, let us discuss them together. One is catalepsy and the other is posturing, okay. So catalepsy and posturing, both of them are similar, okay. Both of them basically mean that patient has some odd posture, patient is maintained a very odd posture for a long time, okay. Now please remember, this is catalepsy. There is something known as cataplexy, which is a different term which we will discuss in narcolepsy. It's a sleep disorder. This is catalepsy. Now, so if you see, in the image, the patient is maintaining a very odd posture, and this posture he may maintain for a long time. This is, either catalepsy or posturing. So what is the difference? The difference is catalepsy is a passive phenomena. So let us say, the examiner or the doctor made the patient stand like this, and now the patient is maintaining this posture for a long time, then it is catalepsy. While posturing is an active phenomena. Active phenomena means that the patient himself has got into this posture and now he's maintaining this posture for a long time, okay. These are very difficult posture. One patient is just standing on 1 feet for hours and hours. So this is catalepsy or posturing. Nowadays a lot of image based questions are asked, so they may ask you such question. But please remember, in the option they may give you either catalepsy or posturing. If both the options are given, they will tell you whether it is passive or it is active, okay. Now next symptom again, very interesting symptom, waxy flexibility. So waxy flexibility means there is a feeling of resistance while making the passive movement on the patient. Okay, just like when you try to mold a wax candle, there is initial resistance and then you can bend the candle the way you want. Okay, so similarly, if you try to move the patient, initially there will be resistance and after some time you can move the patient the way you want. This is waxy flexibility. So patient can be molded like a bending wax candle. Okay, this is waxy flexibility. Now the next two symptoms, let us try to understand them together. Very interesting. One is negativism and the other is automatic obedience. As the name suggests, negativism, as if the patient has developed a very negative attitude towards the examiner. Okay, so negativism is basically the patient either oppose or give no response to the instructions. You give some instructions to the patient, either the patient will show no response or he will do the opposite. For example, let us say you ask the patient to come forward. Either the patient is sitting on his position, he is standing on his position, no response, or he may go backward, so he may just do the opposite. This is negativism. While what is automatic obedience, it is just the opposite. Now the patient has become excessively cooperative, extremely cooperative. Whatever you tell him, he will do, even if it is harmful to him. For example, let us say you tell the patient you have a needle in your hand and you say that I will prick your tongue with this needle. You have told him and now you tell the patient to pull out his tongue. The patient will pull out the tongue. You prick the tongue with the needle. Again you tell him pull out the tongue. Again he will pull out the tongue. So whatever you will say, the patient will do. He is obedient, automatically obedient to the instruction. So one is negativism and the other is automatic obedience. Now next two, we can again discuss them together. One is mannerisms and the other is stereotypy. Both of them basically means repetitive odd movement. So patient is doing some movements which have become very repetitive, which have become very odd. Okay, so what is the difference? Again, you can remember from the name itself, mannerisms means that there is some manner. Okay, these movements, although they are repetitive and odd, but these are purposeful movements. Purposeful movements. For example, patient is doing like this. What is this? This is a salute movement. So it seems to have a purpose, but now it has become very repetitive and it become odd. So now we say it is mannerisms. Sometimes questions are asked just on these terms itself. So you should know these terms. Now next is stereotypy. Now stereotypy, again they are repetitive odd movements. These are non-purposeful movements. Non-purposeful movements. Okay, so now these movements like this, these movements again they have no purpose, but they are repetitive odd movements. So this is stereotypy, right? Now next two, again we can discuss them and again try to remember them from the name itself. One is echolalia. What is echo or echo? Echo means to repeat. You go in a valley and you shout your name loud, it will echo back. Okay, so this is echo. And lalia means word. So what is echolalia? It is mimicking the examiner's speech. So whatever you say to the patient will say the same thing. So I ask the patient, what is your name? Patient will say, what is your name? What do you do? What do you do? Where do you live? Patient will say, where do you live? So this is echolalia. Then what is echopraxia? Now again, what is praxia? If you remember, what is praxia? So praxia, so apraxia, what is apraxia? Loss of fine movement, decrease in the fine movements. So praxia means movement. So what is echopraxia? It is mimicking the examiner's movement or actions. Okay, for example, you have a pen and paper and you're writing something in front of the patient. Patient does not have any pen or paper, but patient may start doing the same movement. So he's copying the movement or he's mimicking the movement. Very simple thing, start scratching your head in front of the patient will also start scratching his head. This is echopraxia. Okay, now next is grimacing. Now what is grimacing? Nowadays when you take a selfie, what do? You pout. Now if you maintain this pout for a long time, that is grimacing. So grimacing basically is maintenance of odd facial expressions. Okay, this is grimacing. And lastly, ambitendency. Now please understand, we have read in Bloyler's 4A's, one of the symptom was ambivalence. That was inability to decide at the thinking level. Now ambitendency, it is a tendency, it is inability to decide motor movement. Okay, so what is it? So patient is stuck in some movement, he is not able to decide whether I should do this movement or I should not do this movement. For example, let us say the pen is there on the table, so patient is moving his hand forward, then backward, then forward, then backward. So patient is stuck whether he should pick the pen or he should not pick the pen. So this is ambitendency. Ambivalence was at the thinking level, the person is just thinking, staring at the pen for a long time and thinking that whether he should pick the pen or not. So this is ambitendency. Now, so we say basically these are set of catatonic symptoms. We say if someone has 3 or more symptoms out of these, if someone has 3 or more symptoms out of these, we say patient has catatonic symptoms. Patient has catatonic symptoms. Okay, so these are catatonic symptoms. Now let us talk about some other symptoms which may be seen related to suicide, violence and homicide. Now suicide is one of the most common cause of premature death in patients with schizophrenia, and rate of suicide is around 5 to 6%. So earlier studies would say it was 10%, but the latest studies, DSM-5, they say it is around 5 to 6%, and 20% of the patient actually attempt suicide, but 5 to 6% patient are they are able to have completed suicide. So again these data is again somehow important. Okay, now there are certain risk factors associated with suicide. One of the important risk factor of suicide in patient with schizophrenia is the presence of a major depressive disorder. So patients having depressive disorder along with schizophrenia, they are at risk of committing suicide. And patients with with better or best prognosis, like patients who have few negative symptoms or they have less affect disturbance, paradoxically they also have been shown to have increased risk of suicide. Okay, so maybe because there is a feeling of disappointment, because maybe a feeling that they're not able to perform better in their functioning, because of that there is an increased risk of suicide. Young male shown decline in higher level of functioning, they may develop hopeless about the future, or they may develop hopelessness that treatment is not working. Again risk of suicide may be high. Now patient with increased symptoms like delusion of persecution or symptoms like command hallucination. Okay, many a times patient may hear hallucination voices which may say to jump from the floor or to commit suicide. So again that may also increase the risk of suicide. Then substance use, comorbid substance use again has been shown to have higher risk of suicide. Now it is seen in studies that patients have been hospitalized with suicide attempt or risk of suicide, clozapine has shown to decrease suicidal ideations. Okay, and also of course if there is comorbid depression, again treatment of with antidepressant again will be useful. Now in the violent behavior, if we exclude homicide, it may be seen more with patients who are untreated, more untreated. But again let's try to understand this. Although we have a different belief, but it is seen that these patients are more commonly victims of violence rather than being the perpetrators of violent acts. So they're more commonly seen to be victims, so people may commit violence on them rather than they committing violence on other people. Now again homicide, the rate of homicide, again to the many a times people believe that people who have schizophrenia, the rate of homicide may be high. No, but again contrary to that belief, rate of homicide is nearly similar to general population. Okay, it does not seem to be higher than the general population. Now since we've discussed the symptoms, let us try to understand the diagnosis of schizophrenia. So there are 5 important symptoms. So what are these symptoms? Delusions, hallucinations, disorganized speech or disorganization in thought, then grossly disorganized or catatonic behavior, and negative symptoms. So now we have discussed all these symptoms in the diagnostic criteria according to DSM-5. So these are the 5 symptoms. Let us try to understand what is the criteria. Okay, so according to DSM-5, 2 or more of the symptoms, out of these 5 symptoms, 2 or more should be present, but there is a catch. So if you see, I've highlighted the first 3 with a different shade. Reason being, out of these 2 or more symptoms, at least one symptom should be from the first 3. Okay, at least one symptom should be from the first 3, and they should be present for 1 month. Okay, at least 1 month. Okay, now, but the total duration of disturbance, again this is important, total duration of disturbances should be 6 months. Okay, so DSM-5 says that the duration of disturbance should be 6 months. Okay, and in this 6 months, at least 1 month of active symptoms should be present. At least 2 or more of these symptoms should be present. Okay, so on the, other than these 1 month, in the remaining months, there may be milder symptoms or milder disturbances may be there. Okay, or fewer symptoms may be there. But actively should be 1 month, and total duration of disturbance should be 6 months according to DSM-5. So a patient having delusions and hallucination, a patient is having delusion and hallucination, let us say for 8 months. Okay, is it schizophrenia? Yes. Okay, because there are 2 symptoms and both the symptoms are from the first 3. Another example, let us say a patient is having delusion. So patient suspects that a neighbor wants to kill me, and is also having decreased interest, there is decreased will power, there is decrease in the expression of emotions for, let us say again, for 8 months. Is it schizophrenia? Yes. So patient, these are negative symptoms, and patient is also having delusion. So at least 2 symptoms are there, and one of the symptom is from the first 3, that is one symptom is delusion. Yes, it is schizophrenia. According to ICD-11, the duration is, again symptoms are similar, but the duration is 1 month. Okay, so ICD-11, you should remember it is 1 month. Okay, now generally you can follow DSM-5 until unless they have specified whether they are asking according to DSM or ICD-11. Okay, now in DSM-4 there was some, these were the symptoms, but there was some special significance was given. So DSM-4 had said that if, let us say, patient has just one symptom, just patient has only one delusion, which was a bizarre delusion, then no other symptom may be required. Okay, or if the patient has SFRS type hallucination, like we have discussed, okay, like voices giving a running commentary or voices discussing about the patient, if these hallucinations are present, then no other symptom is required. But this special significance has now been removed. Okay, now have been removed in DSM-5. DSM-5 says at least 2 symptoms should be present. Okay, now there is a newer classification which has been given in both ICD-11 as well as DSM-5. So they have classified schizophrenia now based on the course of illness. So based on the course of illness they have classified. So it can be schizophrenia first episode. So when the patient has first episode, we say it is schizophrenia first episode. It can be schizophrenia having multiple episodes. So if the patient comes to you with another episode, okay, so there was one episode previously and patient has come to you with another episode, and in between these episodes there should be remission. That means that there should be no symptom. So then we say it is multiple episodes. Or sometimes patient may have schizophrenia with continuous course. That means the symptoms are continuously present in the patient. And to diagnose schizophrenia having continuous course, the symptoms should be present for at least 1 year. Okay, so this is a newer way of classifying schizophrenia, both according to ICD-11 and DSM-5. Also these you can further give certain characteristics, like they are either currently symptomatic, or there is partial remission, there is full remission, or if it is unspecified. Okay, so these again course can be further specified like this. So please remember this. These are newer ways of classifying schizophrenia. Now subtypes of schizophrenia. Now earlier in ICD-10 as well as DSM-4, now schizophrenia was classified based on the symptoms. Okay, So, but please remember these subtypes have now been removed from the newer classification. Both ICD-11 and DSM-5 have, removed these subtypes. But again, for our understanding, let us discuss them. So basically, they say that their long-term stability is not there that much, so that is why they've removed these subtypes. But let us try to remember again. Many questions may be asked from these subtypes. Let us try to remember these subtypes based on the symptom. So you can remember these subtypes with the mnemonic PHC. PHC, that is primary health center, is our USP of our country. So you can remember these subtypes with the mnemonic PHC is our USP. Okay, let us try to remember these subtypes one by one. First is paranoid schizophrenia. So first subtype is paranoid schizophrenia. Please remember, it is the most common subtype. So in paranoid schizophrenia, predominantly patients have delusions and hallucinations. It is generally, it occurs at a later age, okay, in the 30s and the 40s. So it has slightly later age of onset. So again, if I ask you about the prognosis, what kind of prognosis will be? It has a good prognosis. It has good prognosis. And generally we see that the personality is preserved in these patients. So their, social, occupational functioning, their day-to-day behavior, it seems to be the same. So the personality does not seem to be that much affected in paranoid schizophrenia. Okay. Second is H. H stands for hebephrenic or disorganized schizophrenia. Again, as the name suggests, patient here has disorganized symptoms. Patient has disorganized thought. There may be formal thought disorders or disorganized behavior may be there. A lot of time these patients you will find having symptoms like giggling or smiling to self or mirror gazing. Okay, it is seen that these patients have an early onset. A lot of the time maybe in the before 20s or before 25 years of age, they generally have an onset. Okay, so they have an early onset. So what will be the prognosis? How will be the prognosis? Prognosis is generally poor, and you'll see that there is severe personality deterioration seen in these patients. Okay, so their functioning seems to be significantly impaired. Their personal hygiene may be disturbed. So very disorganized behavior will be seen. This is hebephrenic or disorganized schizophrenia. Next is C. C stands for catatonic schizophrenia. As the name suggests, these have predominant catatonic symptoms. Of course, please understand this. I'm not saying they will just have catatonic symptoms. Then you will not be able to make the diagnosis of schizophrenia. Of course, other symptoms are also present, but predominantly catatonic symptoms are there. Okay. Now, very interesting is treatment. Now, we'll talk about treatment of schizophrenia. We will discuss, we treat it with antipsychotics. But when patient has predominant catatonic symptoms, suppose, the family members have brought a patient to you and they say that the patient, is not speaking, there is mutism and patient is maintaining such odd behavior or posture, and they brought to you. His patient is not eaten food, for much time. And you give him some medicine or give him some drug, and maybe within few minutes or few hours the patient may have improvement in the symptoms. Which is that medicine you have given? It is lorazepam, IV lorazepam. Parenterally we may give IV IM, and then of course later on oral we may also shift. So you give lorazepam and the patient may show improvement in symptoms. Okay, so lorazepam is one. Another treatment which we can give is ECT. What is ECT? Electroconvulsive therapy. Even ECT. So, but of course, if you have to choose one, initially you will start with lorazepam. But yes, ECT is also a treatment. So for catatonic symptoms, so the treatment is lorazepam, IV lorazepam, and then ECT, of course. But if to choose one, you have to initially you'll choose lorazepam. So please see, patient has come with such significant symptoms and patient has responded well to this medication. So what will be the prognosis of catatonic schizophrenia? It has good prognosis. In fact, out of all the types of schizophrenia, it has the best prognosis. Catatonic schizophrenia has the best prognosis. Okay. Now, next is R. Okay. So what is R? residual schizophrenia. R is residual schizophrenia, as the name suggests. So patient has, in early stages, patient has symptoms of delusions and hallucination, and now they have become minimal. So minimal delusions, hallucination, and mostly the symptoms which are present are negative symptoms. So this subtype of schizophrenia is known as residual schizophrenia. Then USP, U stands for undifferentiated. Undifferentiated. So in pathology, many times when you're not able to see whether it's a meso, chimal or an endo, dermal cell. So we say it's an undifferentiated cell. So what is undifferentiated schizophrenia? When there are features of more than one subtype. You're not able to differentiate or put it into one particular subtype. Okay, so patient may have symptoms of delusions, hallucinations also, catatonic symptoms are also there, disorganized symptoms may also be there. So you're not able to differentiate it into or put it into one particular subtype. Then we say it is undifferentiated schizophrenia. So there is a mixture of symptoms. Mixture of symptoms are present. This is undifferentiated. Next is simple schizophrenia. Now the name is simple, but this subtype is not that simple. Patient has predominant negative symptom. Predominantly patient has negative symptoms, and we have discussed negative symptoms generally don't respond well to medication. Okay, so in fact it is seen that simple schizophrenia has the worst prognosis, out of all the subtypes. Simple schizophrenia has worst prognosis. In fact, ICD-10, these subtypes are no longer present in ICD-11. ICD-10 said that if you have made the diagnosis of schizophrenia and you are making the diagnosis of simple schizophrenia, wait for at least 1 year. If the symptoms are present continuously for 1 year, then call it as simple schizophrenia. Okay, you have made the diagnosis of schizophrenia in 1 month according to ICD-10, but it says that to make a diagnosis of simple schizophrenia, the symptoms should be present for at least 1 year, because it has worse prognosis. You're saying someone has simple schizophrenia, and again you have to wait the symptoms to be present for at least 1 year. Okay, this is simple schizophrenia. And lastly, P is post schizophrenic depression. Post, as the name suggests, so in the past 1 year patient had symptoms of schizophrenia which have now been improved. So symptoms of schizophrenia is improved, and now the patient has developed depressive symptoms, like there is sadness of mood, decreased interest, decreased energy, decreased appetite. So patient has now developed depressive symptoms. So this is, as the name suggests, post schizophrenic depression, depression after episode of schizophrenia. Okay, again one important point, interesting point is, again, risk of suicide we have discussed in schizophrenia is higher than the general population. Risk is even higher. The risk is even higher of suicide in this particular subtype. Okay, so this is post schizophrenic depression. So these are important subtypes of schizophrenia. Now there are certain other classifications as well. Now there was an earlier classification by T.J. Crow. He has classified schizophrenia into 2 syndromes, that is type 1. So he has divided into type 1 and type 2. So type 1 prominently had positive symptoms, while type 2 have negative symptoms. So again, as we've discussed, so type 1 will respond to the medication or treatment will be good, while type 2 will have a poor response to treatment. Now if you see the ventricles, or if you do a CT scan of the brain, the ventricles are normal in size, while type 2 they have dilated ventricles. And again, prognosis, type 1 will have good prognosis, while type 2 will have poor prognosis. So this is another classification. It's an older classification by T.J. Crow. Now then there are certain other types, like there is Van Gogh syndrome. Van Gogh syndrome, basically what is it? It is self-mutilation, dramatic self-mutilation occurring in a patient with schizophrenia. So this is termed as Van Gogh syndrome. Then POF schizophrenia. So schizophrenia occurring in a patient with mental retardation. Someone with mental retardation developing schizophrenia, that is known as POF schizophrenia. Also, schizophrenic like symptoms or substances may cause schizophrenia like symptoms, like hallucinogens, okay, like phencyclidine, amphetamine, LSD, then other substances like cocaine, cannabis, they may also produce symptoms, induce symptoms like schizophrenia. Okay. Now, one interesting point in ICD-11 is that they have, please understand, catatonia is basically a group of motor signs and symptoms. So we've discussed catatonic symptoms. Now we've discussed catatonic symptoms in schizophrenia. Does not mean that catatonic symptoms may not be seen in other conditions. Okay, in fact, we see catatonic symptoms more commonly with mood disorders than even schizophrenia. Now, what ICD-11 as well as DSM-5 they have done is they have separated catatonia into a separate category, into a separate diagnostic category. So which includes catatonia associated with another mental disorder, like as we discussed, mood disorder, patient may have catatonic symptom, or schizophrenia, even autism spectrum disorder, patient may have catatonic symptom. Then catatonia induced by psychoactive substance including medication. So even substances or certain medication may also induce catatonic symptoms. And lastly is if it is unspecified, it may be occurring because of any other condition. For example, in encephalitis, patient may develop catatonic symptom, and other condition, then we say catatonia unspecified. Okay, so again catatonia may be, the ICD-11 has made separate diagnostic category of catatonia. Okay, now let's talk about prognostic factors. So certain factors, prognosis or outcome, nowadays we talk a lot about outcome. So certain factors if are present in a patient may have better or good prognosis, and some of the factors may have bad prognosis. So let us discuss these, again important. So in good prognostic factors, let us try to discuss them. In good prognostic factors, the onset. So what is the onset? Let us discuss prognostic factors. So good prognostic factors and bad prognostic factors. In the good prognostic factors, one is the onset. So acute or abrupt onset. So if the symptoms start suddenly, okay, abrupt generally we say if the symptoms start within 2 days, or if the symptoms start within 2 weeks, acute onset. From normal to abnormal state, that is onset. So if the patient develop these symptoms suddenly, or let us say within 2 weeks, then we say it has a good prognosis. So for example, a family member, they have brought a patient who they say that the symptoms have been present in 8 months, and you have seen that the patient is having schizophrenia. Now when they say that 8 months back when the symptoms started, all the symptoms they started within a span of few days, okay, or within 2 weeks, then we say that this is acute or abrupt onset. Okay, while insidious onset means the symptoms started took months or years. Okay, symptoms started gradually, slowly, then we say it is bad prognosis. Okay, so family members may say that's 1.5 years, 2 years back, we saw certain changes, like there was irritability, sleep disturbances, social withdrawal, and gradually the symptoms developed. So this is insidious onset. It has poor or bad prognosis. Now, age at which the onset is occurring. So if a person has late age of onset, in the 30s or in the 40s, so at a later age, if the patient has schizophrenia, it is good prognosis. While if the patient has the onset at an early onset or at an early age, in the at 10 or 20s, in that age group, if the patient develops schizophrenia, again it is bad prognosis. Now based on the subtype which we have discussed, based on the subtypes, again catatonic schizophrenia we've already discussed it, the best prognosis. Even paranoid schizophrenia has good prognosis. Then simple, hebephrenic, simple we have discussed it has the worst prognosis. Even hebephrenic, undifferentiated, these have poor or bad prognosis. Okay, based on the gender, we have discussed, again females have a better prognosis. The onset is slightly late, they have a better prognosis, while as compared to males who have a poor prognosis. Now prominent positive symptoms, again we have discussed, have a good prognosis, while prominent negative symptoms, they have a poor prognosis. Now this is again important, I want you to remember, understand this. Presence of mood symptoms have a good prognosis as compared to absence of mood symptoms. Mood symptoms, like it can be depressive symptoms or manic symptoms. Okay, Now, please try to understand. So we say that, patient is having schizophrenia, and let us say the patient appears to be, sad, or appears to be depressed, or there are depressive symptoms. Okay, then we say it has good prognosis. Let's try to understand or remember it like this. Now in schizophrenia, we discussed patient has flat affect. There is, no changes in emotions, as if the emotions are dead. Okay, so there are no emotions. So if the patient is showing certain, mood symptom, that means emotions are not totally dead. That means it has a still the emotions there. So you can just for your understanding, you can remember it like this. So presence of mood symptom is good prognosis, absence of mood symptom is poor prognosis or bad prognosis. Now another important point, this again I want you to remember again, because many times, students get confused in these 2 points. Family history of mood disorder. So let us say there's a patient of schizophrenia and his father has history of bipolar disorder. Let us say sister has history of depression. So there is family history of mood disorder has better prognosis as compared to someone having family history of schizophrenia. Let us say patient's, mother had schizophrenia, and let us say sibling also has schizophrenia. So if you compare the two, with family history of mood disorder has good prognosis as compared to family history of schizophrenia. Again, you can remember it like this. Someone having family history of schizophrenia, more of genetic loading may be there, more of genetic factors may be involved. Okay, so it has bad prognosis. So these 2 points again are very important. Now next is, someone is married. Okay, so married is a better prognosis as compared to someone who is unmarried, is divorced or separated. Now, because again, schizophrenia, someone is married, maybe there is good social support. Okay, good social support. So marriage has good prognostic factor. Again, good social support, there are people who are helping, there are people who are taking care of the patient, taking care of the medication, taking, care of regular visits to the doctor. So again, good social support has good prognosis, poor social support has poor prognosis. Patient with good pre-morbid functioning. Pre-morbid means, pre means before, morbid means illness. So if a patient who has developed schizophrenia, let us say at the age of 30 years he's developed schizophrenia, but before that, before the illness, the patient was functioning well, he was having a regular occupation, social functioning was also good, maintaining self-care, we said those patients have better or good prognosis as compared to another patient. Let us say he's developed schizophrenia at the age of 30 years, but family members say even before that he would not do much work, he was inconsistent in his, occupation, does not had, good social relations. So again, poor pre-morbid functioning may have poor prognosis. If the person is employed, there is employment is present, so again it has good prognosis, while someone who is unemployed, again poor prognosis. Precipitating factor, if any precipitating factor is present, so let us say at the time of illness, family members say there was a stressor, the patient had a huge financial loss, or there was some relationship problem, after which the patient developed the symptoms. So there was a precipitating event was there, that has good prognosis, and someone without any precipitating factor has developed schizophrenia, it has bad prognosis. So these are some important points on good and bad prognostic factors of schizophrenia. Now let's talk about treatment of schizophrenia. Now basically treatment of schizophrenia, the first line is antipsychotics. So we use antipsychotics, which are also known as neuroleptics. Okay, so there are 2 classes of antipsychotics. First is the first generation, okay, or the typical antipsychotics. So in schizophrenia we have first generation or typical, and second generation or the atypical antipsychotics. Okay, so we have 2 classifications or 2 classes of antipsychotics. Now basically the difference is the mechanism of action. Okay, mechanism of action is different. Now we have discussed, if you remember in the etiology, we have talked about the dopamine, levels are increased. Okay, so in first generation the mechanism of action is that they are D2. D2 is a receptor of dopamine. So dopamine has various receptors like D1, D2, D3, D4, D5. It is a D2 antagonist. So mechanism of action is D2 antagonist. Why atypical? Why they are known as atypical? Because not just they block D2. So if you remember again, let's go to the etiology. So we have also discussed even serotonin level is increased. So they have D2 as well as 5-HT is what? 5-HT is serotonin receptor. 5-HT 2A antagonist. Okay, so it is not just D2 antagonist but also 5-HT2A. So you can remember it like this. So both of them are 2. Okay, and A, you can remember A for atypical. Okay, so just for your remembering, you can remember 5-HT2A antagonist. Okay, now when we compare first generation and second generation, it is seen that the first generation has more of EPS. EPS is what? Extra pyramidal symptom. We'll talk about this in detail, various types of EPS. These are basically movement disorders associated with the antipsychotics. So these are more with with the first generation, while they are less EPS with the second generation. Now, then there are certain metabolic side effects like weight gain, diabetes, hypertension, hyperlipidemia. It is seen they are more with the second generation. Second generation antipsychotics are more of these metabolic side effect and less are there with the first generation. And also it is seen that first generation have they they help in the positive symptoms, while the second generation they help in both positive and negative symptoms of schizophrenia. Okay, now so when we talk about duration of treatment of schizophrenia, so suppose a patient has come to us with the first episode. So patient has come and he has never had schizophrenia in the past, and you started antipsychotics and the patient is shown improvement. Now the family member says, sir, he's all well, should we stop the medicine? What should you say? We should say no. So after complete improvement, we have to continue the drug for at least 1 to 2 years after the first episode. Okay, because if we stop the drug in between, again there are chances of relapse. So if you're asked what is the minimum duration of minimum duration you have to continue the drug, it is 1 year. And if to ask, if both 1 and 2 years are there in the option, which would be a better answer for continuation of treatment? 2 years. So for minimum 1 year, and overall we say for one episode at least continue the medicines for 2 years. Now suppose this patient, they took it for 6 months and now they stopped the medication, and after some time they again come back to you with another episode of schizophrenia. So again you have started the patient on antipsychotics and again patient has shown improvement. Now again the family members would ask, now sir, it is the second time. So if it is 2 or more episodes of schizophrenia if the patient had, now then for how long should we continue the medication? So please remember, it is 5 years, minimum at least for 5 years, and it may be even indefinite. So we may have to continue for a longer time. Okay, I'm not saying always that it should be lifelong, but again indefinite, it may have to continue even longer. So minimum duration would be, if 2 or more episodes occur, then minimum duration is 5 years. So this is about the duration of treatment with antipsychotics. So the side effects of antipsychotics, especially now two important side effects which we will discuss, which is because of D2 antagonism. Let's try to understand them in detail. Okay, so let us talk about the movement disorder or extrapyramidal symptoms. Extrapyramidal symptoms or EPS or extrapyramidal side effects. Okay, now why they occur? They occur because of blockage of, so they occur because of blockage of the D2 receptor. Now we've discussed that there are two dopamine pathways were involved in the symptoms. Okay, we have discussed mesolimbic and mesocortical pathway, two important pathways here we will discuss which are related with the side effects. Okay, so since they are the antipsychotics are blocking the D2 receptors, so even in these pathways also the D2 receptors are blocked. So the first pathway here is nigrostriatal pathway. Okay, so we'll talk about this in detail. So basically these EPS are more with typical antipsychotics as compared to atypical, because the typical ones are totally blocking the D2 receptors. Okay, and especially the high potency drug, okay, which have high affinity for the D2 blockage, they have more of these EPS. And if we compare drugs which are given through parenteral route, like IV or IM route, they seem to have more of EPS as compared to the oral drugs. Okay, now so there is, as we have discussed, there is blockage of the D2 receptor in the nigrostriatal pathway. Let's try to understand this, let's try to conceptualize things so that it becomes easy for us to remember. So nigro basically means the substantia nigra. So it starts from the substantia nigra to the basal ganglia, to the in the striatum. Okay, so it goes from the substantia nigra to the striatum. Now if you can let's use our knowledge of medicine. There is, a disease known as Parkinson's disease, or Parkinsonism. There we know that there is, in Parkinsonism, what are the symptoms? Patients have, there are tremors, rigidity, bradykinesia, a lot of movement symptoms are there. Okay, so because they occur because of decrease of dopamine in these, areas, the symptoms, these motor symptoms are produced, and, in the treatment we then give, dopamine from outside, we give levodopa. So let's try to correlate this concept. Now in antipsychotics, what we are doing is we are giving, what we are doing is we are blocking the D2 receptors. We want to block D2 receptor in other pathways, but even in this pathway also, the dopamine, the D2 receptor is getting blocked. Okay, so there is a decrease of dopamine, and then there is production of these motor symptoms, EPS. Okay, so we can correlate like this. Okay, so this is, what is the mechanism of these EPS. Now let's try to understand some of the important EPS. So what are the important types of extrapyramidal symptoms? So you can remember it with a mnemonic. So when you have a fest in your college, so there may be a dance party at night, so you can remember it with the mnemonic DP at night. Okay, so these are the extrapyramidal symptoms. So D stands for dystonia. There is acute dystonia. P is Parkinsonism, drug induced Parkinsonism. Sometimes it is also known as pseudo Parkinsonism. Okay, then A stands for akathisia. T is tardive dyskinesia, and N is neuroleptic malignant syndrome, or NMS. So you can remember these, extrapyramidal symptoms through this mnemonic. Let's try to understand these one by one. Now first is acute dystonia. Acute dystonia, the onset is earliest, so it occurs, out of all the EPS, it occurs earliest. Can occur even within few minutes after you give parenteral medicine. So within, few minutes you have given IV or IM drug, antipsychotic, the patient may develop symptoms, or if you given orally, it may, may occur, after some hours. Okay, so what is acute dystonia? There is sudden muscle contraction, sudden, muscle spasm of group of muscle. So it may occur, in the extraocular muscle. So there may be, eyes may be, rolled upwards or towards the side. So that is also known as oculogyric crisis. The neck, head and neck muscles may be twisted to one side. Patient may come like this, sir, I'm not able to move my neck. This is torticollis. Or there may, the jaw muscles again may be contracted, or trismus. Even laryngeal muscles may be, in spasm, laryngospasm, and even the glossopharyngeal dystonias may be seen, like dysarthria, dysphagia, and sometimes patient may have breathing difficulty. So they are very distressing side effect. Patient comes with sudden, acute contraction of a group of muscles. Okay. Now, generally, how do we treat? Treatment is basically by giving parenteral anticholinergic drugs. Okay. So like benztropine, diphenhydramine, promethazine. So we give them, parenterally, and of course, prophylactically, when you have started a patient on antipsychotic, sometimes prophylactically, to prevent these dystonias, you can give oral anticholinergic drugs. Okay, so again, treatment is also important. This is acute dystonia. Now second is P, that is drug induced Parkinsonism, okay, or pseudo Parkinsonism. Now the onset is usually in days or weeks. Okay, so they have symptoms similar to seen in Parkinson's disease. So patient may come to you with, there are tremors, coarse tremors are there, there is rigidity, bradykinesia may be there, and sometimes, perioral tremors may be seen. Okay, these are basically also known as rabbit syndrome. Okay, so perioral tremors, so in the vertical line of the mouth, such movements may be there, and usually they occur at a later stage. Okay, so patient comes to you on antipsychotic with tremors, rigidity, slowing of movement, bradykinesia. So this is what, this is drug induced Parkinsonism. Now coming to the treatment, we use anticholinergic drugs, okay, like benztropine or diphenhydramine, trihexyphenidyl. Okay, so we use these drugs. Again, other strategies like reducing the antipsychotic drug, or changing it to, an atypical or a low potency typical antipsychotic. So drugs which have, less chances of EPS may be used. So these are certain other strategies which we can use. Next is akathisia. Now out of all the EPS, akathisia we say is the most common EPS. Okay, and akathisia basically means restlessness. Okay, patient is restless. subjectively subjective restlessness is there, so there is a subjective feeling. Patient will say, I'm feeling very restless. And objective signs also, you can see the patient, and objectively also you can see that patient is appearing restless. For example, even if he's sitting, there is rocking motion, okay, while sitting, rocking motion, or he's pacing around in the room. Family members may say that he does not sit, they keep on pacing around. Or he's sitting and then standing, rapid alteration of sitting and standing. If he's standing, he may from one feet to another, he may do like this, hopping movements he may do. Okay, so this is objective signs of restlessness are also seen. Now in akathisia, in the drugs, we say beta blockers like propranolol is the drug of choice. Okay, is the drug of choice for akathisia. And then anticholinergic benzodiazepines also we can use. Again, other strategies like we can reduce the drug or change to an atypical or a low potency typical antipsychotics, that can also be done. But please remember, drug of choice is beta blocker like propranolol. Next is tardive dyskinesia. Tardive basically means late onset. Okay, so it occurs generally months or maybe sometimes years after the treatment. Okay, so they occur late in the treatment. And dyskinesia means abnormal movement. Now basically these occur now because of super sensitization of the D2 receptors. So D2 receptors are chronically getting blocked, so receptors gradually there is super sensitization of the D2 receptors. And symptoms generally you see involuntary movements like lips smacking or chewing movement. Patient is continuously having this chewing movement, or tongue protrusion like fly catching, patient is showing this movement, or coriform movement, hand movements like piano playing movements may be there, pelvic thrusting movements may be there. So patient having such involuntary movements which occur late in the treatment. This is tardive dyskinesia. Now in tardive dyskinesia, you can we should reduce the dose, or if possible, if we can stop the drug. Now you can switch to drugs like clozapine. We'll talk about clozapine. It's an atypical antipsychotic which has one of least EPS causing drug. Or if patient is on typical or high potency drug, you can shift to an atypical antipsychotic which have less propensity for EPS. Now in the drug we can use valbenazine. The drug valbenazine, which has been approved for tardive dyskinesia, it basically inhibits the VMAT2 receptor, that is vesicular monoamine transporter 2. So basically what it does is that it decreases the dopamine. Okay, it inhibits the transfer of dopamine in the vesicles, so the vesicles are not released in the synapse. Okay, there is decrease of dopamine, or they are also known as dopamine depleter. Okay, another similar drug tetrabenazine may also be used. So if you have to choose drug, valbenazine can be used for tardive dyskinesia. Okay, and lastly, neuroleptic malignant syndrome, NMS, as the name says, malignant. Okay, it is a life-threatening complication. It is a life-threatening complication, and the symptoms include patient may have fever, rigidity, there is increased in the creatine phosphokinase, CPK levels are high. Along with this, other symptoms like tachycardia, there may be excessive diaphoresis or sweating, patient may have leukocytosis, altered consciousness, patient may appear confused, even the liver enzymes may be increased. Okay, so these are the symptoms which may be seen with neuroleptic malignant syndrome. So patient on antipsychotic coming with fever, rigidity, CPK levels are high, there is tachycardia, sweating, such symptoms are there, then you should look for neuromalignant syndrome. Now basically again what is happening is there is blockage of D2 receptor due to blockage is there in the striatum, which is leading to muscle rigidity, muscle contraction as well as rigidity. Now dopamine in the hypothalamus is getting blocked, so which is leading to temperature dysregulation. There is increase in the temperature, there is fever, and in the spinal neurons, because of dopamine blockage, there is autonomic disturbances. So there is tachycardia, and these symptoms are seen. Now so basically because of muscle injury, there is increase in CPK levels. One have to be very careful because it may lead to myoglobinuria, and ultimately there may be renal failure and the patient may also die. Okay, so this is again important complication which can occur. Now coming to the treatment, first is we should stop the drug. So any antipsychotic which is causing NMS, you should stop the drug. Supportive care is very important, like adequate hydration, maintenance of vitals is important. In the drugs, the drug of choice for NMS is dantrolene, okay, which is a skeletal muscle relaxant. Okay, then there are other drugs which we can use, like bromocriptine and even amantadine. These are dopamine agonists. These can also be used, but you have to choose one drug. Drug of choice is dantrolene. Okay, now if you have to start, again you have to restart antipsychotic again, you can choose a second generation antipsychotic, okay, which has less EPS potential. You can use second generation antipsychotic. Okay, so this is management of neuroleptic malignant syndrome. Now, another important side effect, especially which occurs because of D2 blockage, are the endocrinal side effects. Okay, they occur because of the D2 blockage in the tuberoinfundibular pathway. So basically, tuberoinfundibular pathway, tubero is the hypothalamus. It starts from the hypothalamus towards the infundibular, that is the anterior pituitary gland. Okay, so it goes from hypothalamus to anterior pituitary. Now let's try to understand what is happening. Now dopamine has an inverse relation with prolactin. Okay, so if dopamine is increased, the prolactin levels decrease and vice versa. Now when we use antipsychotics, okay, so what are we doing? We are blocking the D2 receptor, we are decreasing dopamine in this pathway also. So if dopamine is decreased, what is happening? The prolactin levels are increased. The endocrinal side effects which are occurring is because of increase in the prolactin. Okay, so the prolactin levels are increased. So because of this hyperprolactinemia, we are getting certain side effects, especially the sexual side effects. Okay, so in females and males, there is decreased libido, there is sexual dysfunction, and in females there is also galactorrhea is there, and so galactorrhea, there is milk secretion from the breast, and even amenorrhea, cessation of menses may also be seen. This is occurring because of blockage of dopamine in the tuberoinfundibular pathway. So this is the concept behind some of these important sexual side effects related with antipsychotics. So again, you can see, it is occurring because of D2 blockage. So in typical antipsychotic, these are more common than the atypical ones. Now let's talk about the first generation or the typical. So let's talk about the first typical or the first generation antipsychotics. Let's discuss them. So first group is the phenothiazines. Okay, phenothiazine. So you can remember that all these drugs are ending with azine. Okay, like chlorpromazine, then triflupromazine, then thioridazine, mesoridazine, then fluphenazine, trifluoperazine, prochlorperazine. Okay, so all these drugs are ending with azine. So you can remember it like these are phenothiazines. Then thioxanthines. Thioxanthines, again, they have in them, if you want to remember, there is thix is present in the name. Thiothixine, flupentixol, zuclopenthixol. Okay, so these are thioxanthines. Okay, then butyrofenones are there. Again, they have peridol in the name, so you can remember haloperidol, droperidol, benperidol. Okay, these are butyrofenones. And then miscellaneous drugs like pimozide, penfluridol, loxapine, and molindone. See, these are some of the typical or the first generation antipsychotic. Now please remember, these drugs, like chlorpromazine, thioridazine, these are low potency drug. So the D2 blockage or the affinity towards D2 is less. So if they have low potency, so EPS will also be less. While drugs like fluphenazine, trifluoperazine, then butyrofenones like haloperidol, these drugs have high potency. They are high potency drug. They have more D2 blockage. So more EPS will be seen in these drugs. Okay. Now, so side effects, when we talk about side effects of the typical, if we talk about side effects of the typical antipsychotics. Now, so one is because of the D2 blockage. Because of the D2 blockage, we have discussed, patient may have EPS or endocrinal side effects, and these will be more with the high potency drugs like haloperidol. Okay, they will be like haloperidol. Okay, so effect is also because of D2 blockage in the other pathway, but it also causes side effect because of D2 blockage in the two different pathways we have discussed, which leads to EPS as well as sexual side effects. Now, also these typical antipsychotics may block certain other receptors like M1 blockage, muscarinic receptor blockage is there, which will lead to anticholinergic side effects like there is dry mouth, there is urinary retention is there, constipation is there, blurring of vision is there. So anticholinergic side effects may also occur because they may also block B1 receptor. Then alpha 1 blockage also is there, may be seen, which leads to orthostatic hypotension. Okay, so orthostatic hypotension may occur because of alpha 1 blockage, and they may also block H1 receptor, histaminic receptors, which may lead to excessive sedation. Now, these M1, alpha 1 and H1 blockage is more with the low potency drugs like chlorpromazine or thioridazine. Okay, so these side effects like anticholinergic side effect, sedation, orthostatic hypotension may be more with these low potency drugs. Okay, now some important specific points about individual drugs. Chlorpromazine. Chlorpromazine, as we have discussed, again it's a low potency drug. It can lead to anticholinergic side effect. Again, you can remember chlorpromazine. It can also lead to corneal and lenticular deposits. Okay, so deposits in cornea and the lens may be there. Also, it can cause photosensitivity. Again, you can remember C for chlorpromazine, C for cholestatic jaundice may be, or obstructive jaundice may be seen. Now, chlorpromazine is one of the drug with maximum sedation. Then another drug, thioridazine. Again, thioridazine, you can remember it has an R. Again, it also affects the eye. It causes retinal pigmentation, which is irreversible. It causes retinal pigmentation. It also prolongs the QTC interval, so cardiac arrhythmias may be there. And it is out of all the typical ones. So we know typical drugs generally have high EPS. Out of all the typical antipsychotic, it has the least EPS. Even chlorpromazine also has less EPS. Okay, because these are low potency drugs. Okay, other side effects are more common. Okay, so please remember these side effects related with the eye as well. Chlorpromazine, corneal and lenticular deposit. Thioridazine, retinal pigmentation. Then penfluridol, it is a drug antipsychotic with longest acting antipsychotic. Loxapine, again, which we have discussed in the miscellaneous drug, it also is available as intranasal formulation, so it can also be given through nose. Intranasally it can be given, loxapine. Now, coming to the atypical or the second generation antipsychotics. Now, again, as we have discussed, they block D2 as well as 5-HT2A receptors. They have less EPS, less of hyperprolactinemia, so less of those sexual side effects, but metabolic side effects are more, like weight gain, diabetes, hyperlipidemia, hypertension, cardiovascular disease. They are more with the second generation antipsychotics. Okay, now these are some of the atypical or the second generation antipsychotics like olanzapine, chlorpromazine, quetiapine, zotapine, acinapine. Okay, then amisulpride, sertindol, lumateperone, lurasidone. Okay, then drugs like risperidone, paliperidone, iloperidone, ziprasidone. Okay, then aripiprazole, brexpiprazole, cariprazine and pimavanserin. Okay, so these are some of the atypical or the second generation antipsychotics. Now, let's discuss some of the important points related with each of these drugs. So, olanzapine has, again, olanzapine is a very common drug we use, and it is one of the drugs which has weight gain is commonly seen with this. Now, risperidone, although it's a atypical antipsychotic, but out of the atypical antipsychotic, it is one of the drug with high EPS is there, and also so risperidone has increased EPS as well as hyperprolactinemia. Even with amisulpride, drugs like amisulpride as well, with amisulpride also hyperprolactinemia is more seen. Okay, generally we have discussed that these have less EPS, but again risperidone is one drug which has high EPS as well as hyperprolactinemia. Ziprasidone is one drug which is again known to increase the QTC interval, so cardiac arrhythmias may be seen.
So the drug acinapine is also, in fact, is given through the sublingual route. So the route used for acinapine is sublingually.
Now, let's talk about these three drugs. Generally we have discussed that the atypical drugs, they are D2 and 5-HT2A antagonist. Now, aripiprazole is one drug. Aripiprazole is one drug which is a partial agonist at D2. Important. Okay. Important mechanism. It is a partial agonist at D2. Of course, it is also antagonist at D2 5-HT2A, but please remember it is partial agonist at D2. Similarly, newer drugs like brexprazole, it is also partial agonist at D2 as well as partial agonist at 5-HT1A, and it also antagonizes 5-HT2A. Okay, so these are the drugs which are partial agonist at D2. Even again, newer drugs like cariprazine, it is also partial agonist at D2, also at D3 and 5-HT1A. Please remember here, D3 is more than D2 in cariprazine. The affinity for D3 is more than D2. Okay, and it is also antagonist at 5-HT2A. Okay, so these are certain newer drugs with a slightly different mechanism of action, partial agonist at D2. Then pimavanserin. Pimavanserin, again, it's a newer drug. Now it has a, again, it has an interesting mechanism of action. It is a 5-HT2A inverse agonist. It's a 5-HT2A inverse agonist. How you can remember? You can remember from the name itself. Pimavanserin. Ser is serotonin inverse. So it is 5-HT2A inverse agonist. From the name you can remember it has two A's. It has two A's, so you can remember it is a 5-HT2A inverse agonist. Now this is a drug, FDA approved drug for the treatment of delusions and hallucination in Parkinson's disease associated with psychosis. Now please understand, in some someone having Parkinson's disease would have a lot of movement problems. So pimavanserin is a drug which again has least of EPS. Okay, so it is drug which has been approved because it is not blocking D2 receptors. Okay, so it is a drug which is approved for delusion hallucination in Parkinson's disease associated psychosis. One important point you can remember is it increases QT interval. Even drug like clozapine may be used in such condition because again clozapine also has less of EPS. Okay, but this is one drug which is specifically approved for this condition. Then lumateperone, it is an antagonist at 5-HT2A, D1, D2 and D4. Again a newer drug. It's an antagonist at 5-HT2A, D1, D2 and D4. Now let's talk about one of the very important drugs under the atypical antipsychotic, which is clozapine. It is one of the first antipsychotic which was discovered. Now it is antagonist, but antagonist activities more for D4 than D2. That is why it is one of the atypical drugs with least EPS, because the antagonism is more at D4 than D2. Also, there is antagonism at 5-HT2A, D3 and alpha. Okay, it is the only antipsychotic, as we have discussed, even discussing the subtypes. Okay, so we've discussed that it has anti-suicidal property. It is the only antipsychotic. Okay, in mood stabilizer we know lithium is one drug. Which has anti-suicidal property. In antipsychotics, clozapine is a one drug. So it has shown to decrease suicidal ideations in patients with schizophrenia who were hospitalized previously for suicidality. Okay, so it has anti-suicidal property. Now it is used for treatment resistant schizophrenia. Again, this is important. What do we mean by this? So if a person comes to us for the first time having schizophrenic symptoms, never ever he has been started with any antipsychotic, we will not use clozapine. Clozapine is not the drug to be used for the first time in any patient. It is reserved for treatment resistant schizophrenia. That means patient who has not responded well to other antipsychotics. So generally we say if the patient do not respond to at least two antipsychotics, okay, which have been given for adequate duration and adequate dose, but he has not shown good response, in those patients we can use clozapine. So it is reserved for only treatment resistant schizophrenia. Okay, we'll talk about why. Okay, now clozapine, some of the side effects, side effects with clozapine is it can lead to sedation. Sedation in fact is the most common side effect. It is a atypical antipsychotic, so it can have, lead to metabolic side effects like weight gain. In fact, out of all the antipsychotics, maximum weight gain is with clozapine. Maximum weight gain is with clozapine. Okay, and it can also cause hypotension, tachycardia, sialorrhea or hypersalivation. Again, a very distressing side effect. Nausea, vomiting, constipation it can cause, and it can also lead to anticholinergic side effect, other anticholinergic side effects. Now, clozapine initially, we've discussed one of the first of atypical antipsychotic which was introduced, but it was withdrawn from the market because it was seen that it lead to certain side effects, and one of the side effects led to death in many patients. So it was withdrawn from the market. But later on, it was reintroduced after study done by John Kane, and so Kane et al. So Kane and various other people, they did study, so which showed that clozapine can be used for treatment resistant schizophrenia. So then it was introduced for this category only. Now, so basically clozapine can lead to certain serious side effects. Okay, now you should again very important, you should know, so you can remember it with the acronym, with the mnemonic SAM. First is it can lead to seizures. Okay, so patient again on clozapine can develop seizures. These are basically dose dependent, so higher the dose, more chances. So especially if the dose is more than 600 milligram, then we say that chances of seizure may be more. Then second is agranulocytosis. Agranulocytosis, there is decrease in the WBC count, especially the neutrophil counts. Okay, especially the neutrophil count. In fact, this was the side effect which led to death of many patients, and that is why clozapine initially was withdrawn from the market. So basically, patient is on clozapine, he comes to you, with fever, sore throat. Okay, so again, you may suspect that patient may be having agranulocytosis, and you should check the WBC and the neutrophil counts. Okay, so in fact, it is so important that if we start any patient on clozapine, we weekly monitor for the first 6 months. We weekly monitor the WBC and the neutrophil counts. Okay, and thereafter for the next 6 months we do it after every 2 weeks. Okay, so we have to monitor WBC and the neutrophil count. Okay, and you should stop, we should stop the clozapine if the WBC count is less than 3000 per millimeter cube, and or if the absolute neutrophil count is less than 1500 per millimeter cube. Okay, so this is very important side effect. Another important serious side effect is myocarditis. So you may get a clinical situation in which patient is on clozapine and patient is having chest pain, dyspnea, and patient is having abnormal ECG. So what side effect or what complication you may suspect? It may be myocarditis. Both agranulocytosis and myocarditis are basically idiosyncratic, that is, they are not dependent on the dose. Okay, so these are important serious side effects. Now, important contraindication of clozapine is that if before the start, if the WBC count is less than 3500 per millimeter cube, then you should not. If there is a previous bone marrow disorder is there, again you should not start. History of any agranulocytosis during clozapine treatment has been there, again you should not start. And use of another bone marrow suppressant drug like carbamazepine, again, so if you should not use these drugs together, because again the risk of agranulocytosis will be increased. So if clinical scenario, maybe there a patient has developed seizure, and then you can continue clozapine, but you should also start with some anti-epileptic drug. So which drug you may avoid? You can use drugs like sodium valproate, lamotrigine. Okay, which drug you should not give? You should not give carbamazepine. Okay, why? Because we have discussed that again it also causes bone marrow suppression. It can again exacerbate agranulocytosis. So these are some important contraindications of clozapine, and clinically also we have discussed how this can be asked. Okay, now other than these oral medication, we have another option in antipsychotic, that is long acting injectable LAI antipsychotics, or also known as depot antipsychotics. So basically what we do is we give intramuscular injections, okay, to the patient, and these are basically given, once a month or once every 2 weeks. Some drugs may be even given, every 3 months may be given. So basically we give the drug once, and gradually, the drug is released in the body. Okay, so they especially can be used for patients who have poor compliance to medication. So patient is not taking medications regularly, or compliance is not good. So then in those patients you can go for long acting injectables or the LAI. Now in the depot injection, again we have first generation antipsychotics depot are there, and the second generation. Now first generation antipsychotic, you can remember that these basically have oil base. Okay, so these antipsychotics are in the oil base. So generally whenever we usually give a test dose. Okay, so that just to see if there is any allergy, while no test dose is required for the second generation, because they have they are in the aqueous base. Okay, now then you can remember some of the first generation antipsychotic which are available as depot preparations. You can remember with the mnemonic Fizzy PH. Okay, Fizzy PH. So drugs like fluphenazine, flupentixol, zuclopentixol, then pipotazine and haloperidol. Okay, you can remember it with this mnemonic Fizzy PH. Okay, then second generation antipsychotics which are available, you can remember with the acronym PARO. Okay, that is paliperidone, aripiprazole, risperidone and olanzapine. Okay, now all these drugs basically they are esterified form. So all drugs are esterified forms. So they are esterified forms of the parent drug, except one drug, which is risperidone. Risperidone basically is coated in polymer. So basically risperidone is coated in polymer. Okay, so to produce microspheres. So risperidone is basically available as microspheres. This one point again you can remember. Okay, so test dose is required for first generation, and all others are present as esterified form. Okay, except risperidone, which is available as microspheres. Okay, you can remember this. Now how do we give these intramuscular injection depot preparation? We give it using a technique known as Z-track technique. So basically what happens, suppose you give a patient an antipsychotic depot and you pull out the needle, there is a track which is formed, and there may be oozing of the drug in the other tissues. So to prevent this leaking, or to prevent this tracking back of the drug to other tissues, we use this technique known as Z-track technique. So what happens is, we as in the diagram, we pull the technique slightly, we pull the skin, and then we insert the needle, and then when you pull out the needle, you see there is a zigzag track is formed. Zigzag track is formed so that the leaking of the drug is not there. So this again has been asked previously. Z-track technique is used for depot preparations in antipsychotics. Okay, now other than the drugs, then there are certain psychosocial therapy which is also used. These are basically psychological and social interventions which help in the recovery. Okay, so let us discuss some of the important psychosocial therapies which have found to be beneficial. So evidence based medicine has shown that these have been found to be effective in patients with schizophrenia. You can remember it again with the acronym FAST CASH. You can remember it with the acronym FAST CASH. F is family interventions, assertive community treatment, supported employment, token economy, then cognitive behavior therapy CBT, cognitive remediation, starting with C, then skill training and housing first. Okay, so these are some of the important psychosocial therapies. Let us talk about some important points of each. Family intervention is again it is used to reduce expressed emotions. So expressed emotions like criticism, hostility, over involvement of the family member towards the patient who is suffering from schizophrenia. Many times it is seen that such negative expressed emotions, they are associated with higher relapse. Again important. So emotions like criticism, hostility, over involvement with the patient with schizophrenia, it is seen in studies that there are more chances or higher risk of relapse in such patients. So illness education to the family members, coping skills are taught, emotional support is given in family intervention to the family members. Then assertive community treatment is basically delivering the care to the patients in the community. So reaching out to the patient in the community and giving regular visit and regular treatment to the patient. This is assertive community treatment. Supportive employment. So providing, it has been seen that providing employment again has shown to be beneficial to the patient suffering from schizophrenia. Token economy, again this concept has been used, this therapy has been used. Now generally it is used for inpatient facilities. So basically token is given to for some desired behavior. Okay, so tokens are given, let us say in the ward, patient is behaving well, he is doing certain behaviors, like let us say he's taking taking regular bath, he's regularly making his bed, okay, he's taking part in therapy sessions, he's taking part in other activities which are given. So when such desired behavior is done by the patient, we give him some token, and he can redeem these token for some material items. For example, he can ask for newspaper every day, he can ask for some book or some privileges, like he can ask that he would want to go out in the garden. Okay, so such privileges are then given. So this is token economy. You give a token for desired behavior to increase these desired behaviors. Okay, then cognitive behavior therapy or CBT, again which is also used for depression. So basically it uses certain cognitive and behavior techniques to cope with certain patient is having certain residual symptoms. So how to cope with those residual symptoms, CBT can be used. Cognitive remediation again is important therapy. It has been asked as well previously. It is basically to improve cognitive functions. Now normally again in schizophrenia it is seen that even patients with schizophrenia also have cognitive impairment like attention, memory, executive functioning. Again these symptoms are not at not at present included in the diagnostic criteria, but yes, these patients have certain cognitive deficit. So cognitive remediation is basically to improve these cognitive functions, cognitive remediation therapy. Then skills training. Again there are certain lack of certain skills, especially social skills. So these are social skill training is given and to improve basically social functioning of the patient. Now another interesting therapy is housing first. Again it has been seen that many patients suffering from schizophrenia, especially for a long time, they seem to be homeless. So providing a permanent housing while giving ongoing support, again it's found to show good results in patients with schizophrenia. So these were some of the psychosocial interventions which are used in patients with schizophrenia. After schizophrenia, let us now talk about certain other psychotic disorder. First in this is acute psychotic disorder, okay, or acute psychotic disorders. Now basically as the name suggests, so patient basically acute symptoms are similar to schizophrenia. Patient has delusions, hallucinations, disorganized symptoms are there, but patient does not meet the duration criteria. So we have discussed in DSM-5 the duration should be at least 6 months, ICD-11 at least 1 month. So patient has acute acute duration of symptoms, maybe for 10 days, 5 days patient has these symptoms. So there is abrupt onset of symptoms, and a lot of time it is seen they often resolve completely. Okay, they often resolve completely. Okay, so this is acute psychotic disorder. So patient has symptoms similar to schizophrenia, but the duration criteria is not met. So it is less time. Many a times it is seen that they may be preceded by some stressor. So many times it is seen that acute psychosis may be preceded by, so there may be a precipitating event, like there is a stressful life event. Somebody had some financial loss, or let us say somebody had a breakup, some relationship issues are there. So those patients again may develop acute psychosis. And one important point I want you to remember, in many patients it has been seen that acute psychosis may occur after fever also. Okay, this is one important point why I am discussing this, because in a lot of clinical scenarios you may get such questions. So there is fever and there is sudden onset of symptoms. So patient has fever, sudden onset of symptoms with delusion, hallucination and abnormal behavior. So this is so two important diagnoses may come to your mind. So there are two important differentials. One is, as we are discussing, acute psychosis, and second in the organic mental disorders we discussed is delirium. So if you remember, delirium is also with sudden onset and again delirium has some organic cause, so fever may also be there. So whenever you think of fever, you may think of delirium. So how to differentiate? How will you differentiate? Please remember, we have discussed in delirium there is impairment of consciousness. Impairment of consciousness. Okay. Along with these symptoms, there will be impairment of consciousness. Patient will be confused, or there will be altered sensorium. Okay, so or there is clouding of consciousness. So while no such impairment is seen with acute psychosis, so this is how we can differentiate, because they may appear very similar, and as I told you, fever may also be present with acute psychosis. Okay, now again ICD-11 says, since the duration for schizophrenia is 1 month, so if any symptoms occurring less than 1 month, it is termed as acute and transient psychotic disorder. Again, it is an acute psychotic disorder. And in DSM-5, the term which is used for less than 1 month is brief psychotic disorder. Symptoms present for more than 1 month but less than 6 months, it is known as schizophreniform disorder. Schizophreniform disorder, and of course if it is more than 6 months, we'll call it as schizophrenia. Okay, so they are basically acute psychotic disorders. Now coming to the treatment is again antipsychotics we will use, and for short duration we can also use benzodiazepine to decrease the aggression or agitation. We can also use benzodiazepine, but the mainstay of treatment will be antipsychotics. Second type of other psychotic disorder is schizoaffective disorder. Second is schizoaffective disorder. As the name suggests, again there is present of symptoms of schizophrenia. So there are schizophrenic symptoms, and there are also affective. Affective means mood disorder symptoms are present. Both of them are present for majority of the time during the illness. So both these symptoms, again please understand, we know we have discussed even in schizophrenia sometimes mood symptoms may be occurring, but we don't call it as schizoaffective disorder because this mood symptom may be for a less duration. Okay, but in schizoaffective disorder, so let us try to understand with the help of a diagram. Okay, so we have two patients, let us say patient number A and B. Okay, now patient A has, let us say, delusions, hallucinations for 8 months. Okay, let us say he has delusions and hallucinations for 8 months, and for 2 weeks, let us say patient has some mood symptoms. Let us say patient has sad mood, okay, or depressive symptoms are there. This is patient number A. Patient number B, let us say again he has symptoms of delusions and hallucinations for 8 months. Okay, and also most part of the illness, so let us say around 7.5 months, he also has depressive symptoms. He also has depressive symptoms or depressive disorder. So we have two patients. Now patient number A, we have, as we can see the patient majority of the time has schizophrenia. So the diagnosis for this is schizophrenia. While if you see patient number B, throughout the course of illness, both schizophrenia and mood disorder symptoms are present majority of the time. Okay, so this is schizoaffective disorder. Okay, now there is just one catch. In DSM-5, to differentiate, sometimes in mood disorder we'll discuss even mood disorders may also develop some psychotic symptoms. Okay, to differentiate it from schizoaffective disorder, we say that at least 2-week period of delusions or hallucination should be there without mood symptom. Okay, for at least 2 weeks throughout the course of illness, patient may just have psychotic symptom like delusions or hallucination. Like in this, as you can see, for some duration there is only delusion and hallucination, rest most of the time both the symptoms are present together. This is schizoaffective disorder. So patient may come to you with a 8 months history of suspiciousness, and patient is also hearing voices, and patient is also appearing sad, and patient also has decreased energy, decreased appetite, decreased sleep. Most part of the illness these are present. What is the diagnosis? Schizoaffective disorder. Right. Now Then there are two subtypes of schizoaffective disorder. One is bipolar type, if the mood disorder is, manic symptoms are there, and it is depressive type if the depressive symptoms are there. Okay. Now treatment in, again depending on which, subtype it is. In bipolar type, again, mood stabilizer can be used. Mood stabilizer is used, and along with this we can also add, if required, antipsychotics. While in depressive subtype, antidepressants will be added along with antipsychotics. So we'll try to take care of the schizophrenia symptoms and the mood disorder symptom. This is schizoaffective disorder. Then next is delusional disorder. As the name suggests, the patient is having, what is the symptom? Delusions. Now suppose if a patient just have delusions, can we make a diagnosis of schizophrenia? No. In schizophrenia we have discussed that the patient should have at least two symptoms. So if the patient, because sometimes patient may just have symptom of delusion, then we call it as delusional disorder. Now, so there are one or more delusions which are persistent, and usually these delusions may be related. So when I say related, that means suppose a patient suspects that the neighbor wants to kill me. This is delusion of persecution. Patient also suspects that the neighbor is talking about me. So this is delusion of reference. Patient also suspect that the wife is having an affair with the neighbor. This is delusion of infidelity. So all these delusions in this case are related with the neighbor. So this is how, this is sometimes how the delusions may occur. They are usually related and they are persistent. Now, hallucinations usually are absent. Hallucinations are usually absent, and even if they are present, sometimes they are not prominent and they are for short duration. So patient may just say, maybe just for few minutes, or maybe just for few days, less time, the patient may say that he is hearing voices, and they are not very prominent. Okay, because if hallucinations are also persistently present, then we cannot make a diagnosis of delusional disorder. They may be present, but they are present very, for short duration, and they are not prominent. Okay. Now one interesting point about delusion disorder is functioning is not markedly impaired. Now in any disorder we discussed that there is functional impairment, right? Personal self-care, social functioning, occupational functioning is impaired. But in delusional disorder, the functioning is not markedly impaired, and functioning is normal in areas unaffected by delusion. So other areas, which are not affected by delusion, in those areas the functioning of the patient is fine. Okay. While in schizophrenia, if we compare, we see that in schizophrenia there is marked impairment in functioning. So many times, this also can help us differentiate between delusional disorder and schizophrenia. So if we say this is schizophrenia, a patient is having schizophrenia, so the functional impairment may be occurring in all the spheres of his life. Okay. While let us say this example which we discussed, that patient is having delusion towards the neighbor. So in that particular area, patient is having abnormal functioning or functional impairment. So he may avoid visiting the neighbor. Whenever he sees the neighbor, he becomes very angry. But he's going to the office regularly, he's meeting people regularly. All the other areas of his life are normal. This is how, sometimes we can differentiate, and many times in the question it may be given. A patient suspects the neighbor wants to kill me, is going to his office regularly, meeting the people regularly, taking care of himself. So that is telling you that functional impairment is not markedly impaired. That is delusional disorder. Now, coming to the duration, DSM-5 says that for delusional disorder, symptoms should be present for more than 1 month, while ICD-11, it says duration should be more than 3 months. Okay, right? Now coming to the types, again depending on which type of delusion is there, we can subtype delusional disorder. So it can be persecutory type if it is delusion of persecution. Erotomania type, it can be erotomania type if it is delusion of love. Jealous type, it is delusion of infidelity. Grandiose type, if it is delusion of grandiosity. Then somatic type, as we discussed, there are various somatic delusion, like delusion of parasitosis, delusion of dysmorphophobia, or delusion of halitosis. So if somatic delusions are present, and unspecified may be there, and especially in unspecified, delusion of misidentification. 4 important misidentification we have discussed in the basics, like Capgras syndrome or Fregoli syndrome, syndrome of intermetamorphosis, or syndrome of subjective doubles. Okay, so patient is having misidentification. Like in Capgras syndrome, patient believe that a close person has been replaced by an exact double. Okay, so patient may have such type of delusion, then we call it as unspecified type. Now, there are certain risk factors. There are certain risk factors which may be associated with delusional disorder. Okay, one is advanced age. Now, again, please remember it. In schizophrenia, we had discussed that early onset is a poor prognosis factor. Here, advanced age is a risk factor. Okay, then any sensory impairment or isolation. So, suppose patient is having some sensory impairment, like he's not able to hear, or his eyesight again he's not able to see, blindness is there. So sensory impairment can, or isolation can, lead to delusional disorder. If there is a family history, then again patient can have delusional disorder. Social isolation, personality features like unusual interpersonal sensitivity. So like patient on trivial or small issues, patient becomes developing negative emotions. Okay, these are risk factors. So again, if you see, many of these risk factors would appear to be obvious, like family history, social isolation, certain personality features. Please remember advanced age. Is a risk factor for delusional disorder. Again, it's a psychotic disorder. We say that these patients may be resistant to treatment. Many times, when we start the medicines, they may show some resistance to treatment. That means the drugs may not respond well, but still the drug of choice for such patients is antipsychotics. Okay, so antipsychotics. Then there is something known as shared psychotic disorder or induced delusional disorder. So as the name suggests, sharing, or there is induction of delusional disorder, transfer of delusions from one person to another. So one patient is having delusion, similar delusion may develop in another patient. So there is a primary case who has the delusion. He is the person who generally often has chronic illness, and he is the influential member of the close relationship with the secondary case. Okay, so the other person who is also developing the delusion, he seems to be a more suggestible person. So he is known as secondary case who also develop similar delusion. Okay, so and generally they would they may live closely, and they are close relations. Okay, so this is known as induced delusional disorder. Okay, so a sister is having a delusional disorder. Let us say she is having delusion of persecution. So his sister her sister, who is also living with her closely, may also develop similar delusion. This is induced delusional disorder. Now if two person get involved, this is also known as folie deux, and if it is more than 2%, then it may known as folie trois or quarter if 4, and subsequently like this. It may be these names are given. Now again, treatment is, of course, we will use antipsychotic, and one important point is to separate them. So that again the symptoms may improve, and of course we'll use antipsychotics. Now lastly, then there is something known as attenuated psychosis syndrome. Now this is included in DSM-5, but it is not under the under the official main classification. It is included under the conditions for further study. So in DSM-5 they have added certain conditions which may require more study before they are included in the official classification. So this is attenuated psychosis syndrome. So what is this? So what is the proposed criteria? As the name suggests, attenuated means milder symptoms. So what is the proposed criteria? That at least one of the 3 symptoms are present in the patient or in the person which are in attenuated form, that is in milder form, and the reality testing is intact. That means in as we discussed in psychosis, the reality testing is impaired, their insight is absent. Here the reality testing, touch with real world is there, maybe insight is there. Okay, so for example, so these are the symptoms, that is delusions, hallucination, and disorganized speech. So patient, let us say, is having some hallucinations, patient is hearing some voices. So again, these are milder symptoms. Patient is able to appreciate that these are not real. Okay, so that means it is in the attenuated form. While if it is hallucination, clear-cut hallucination, then patient will think that it is real voice. But here in attenuated form, patient is able to understand that maybe it is not real, it may be an illness. So such symptoms may be there. Then The duration occurs at least once per week for past 1 month, and it begins, or it has begun or has worsened in the past year, and is causing sufficiently distressing and disabling to the individual, and it requires clinic attention. If these symptoms are present, these are the proposed criteria, then it is known as attenuated psychosis syndrome. Again, it has been asked previously in exam, so you can just understand this concept. Okay, so these were some important disorders. Okay, now let us talk about some important questions. Okay, let's try to correlate with the question. So the first question is, all of the following are good prognostic factors except, so please see, sometimes we miss these words. They're asking, so they're asking which of the following is not a good prognostic factor. So let us see. Presence of mood symptoms, it is a good prognostic factor. Prominent positive symptom, we have discussed, it is a good prognostic factor. Being married, we have discussed, it's a good prognostic factor. So the answer is insidious onset, slow or gradual onset is a poor prognostic factor. Now next question. A 15-year-old girl failed in her exams. For 3 days she is claiming, so let's try to, when you see such question, always try to mark certain or identify certain keywords. She is claiming that the teachers are abusing her, and she complained hearing of voices when no one is around. She says that the teachers have conspired against her and want to expel her from school, which is the most likely diagnosis. So let us try to understand what is this symptom when teachers have conspired against her. She starts to believing, starts suspecting. This is delusion. In fact, this is delusion of persecution. Okay, she's hearing voices when no one is around. What is this symptom? This is hallucination. Which type? Auditory hallucination. So patient is having delusions and hallucination. Duration, please see, 3 days. And in the question they've also given stressors. Sometimes they may give, sometimes they may not give. Okay, so what is this? So there are symptoms similar to schizophrenia, but duration is not getting fulfilled. So what is the answer? Now, is it delirium? Is it delirium? No. In delirium, there is impairment of consciousness. It is, yes, it is acute psychosis. It is acute psychosis. It is not mania. Manic symptoms are not there, and it is not delusional disorder, because in delusional disorder, only delusion should be present. Here, the patient is having both delusions and hallucination. Okay. Now, next is a 35-year-old female is brought to the emergency. She is suffering from schizophrenia and is on haloperidol. She presents with symptoms of fever, sweating, disorientation, rigidity for 1 day. Her blood pressure has increased. Okay, so, and on investigation, CPK levels are also increased, and there is leukocytosis. Which of the following is the likely condition? So again, very characteristically, what is this? This is neuroleptic malignant syndrome. Okay, neuroleptic malignant syndrome. And how are you going to treat? You need to stop the drug. You need to give supportive care, and the drug of choice will be dantrolene. Okay, so this is NMS. A 34-year-old male presents with having tinkling sensation in the chest. Okay, which he says is caused by chemicals sprayed by his office colleagues on him. Which of the following is the symptom? So if you see, the patient is having some bodily symptoms. Patient is having some bodily symptoms or some somatic symptoms, which he says is because of some external agency. Because of some external agency. So patient is a passive recipient of bodily sensation which is imposed by some external agency. Is it automatic obedience? No. Automatic obedience is patient is excessively cooperative. Is it visual hallucination? No. Is it delusion of persecution? Patient just does not have delusion. Patient is also having some bodily sensation. What is the phenomenon? What is this? Somatic passivity. It is somatic passivity. Okay, so this was about schizophrenia and other psychotic disorders. Thank you.